So if you go for indications of atrial fibrillation, the consensus came in 2017 and it was modified in 2019, but these indications still remains. So catheter ablation for symptomatic atrial fibrillation, if it is symptomatic, paroxysmal atrial fibrillation, then antiarrhythmic drugs are class 1 indication. If antiarrhythmic drugs failed, then catheter ablation becomes class 2A indication. In case of persistent AFib, antiarrhythmic drugs, then again catheter ablation is class 2A indications. If it is long-standing persistent AFib, antiarrhythmic drugs and catheter ablation is class 2B indications. Let's talk about the modifications. The 2019 focused update on atrial fibrillation came. Those indications still remain intact, but they added, after the Castle AF came, that atrial fibrillation catheter ablations may be reasonable in selected patients with symptomatic AF and heart failure with reduced left ventricular ejection fraction to potentially lower the mortality rate and reduce hospitalization for heart failure. They gave class 2B indications. Okay. So let me go over a couple of my cases, what I did recently. And then, so case 1, 51-year-old male with history of hypertension presented with intermittent symptomatic atrial fibrillation within 2 months despite optimal beta blocker therapy. No history of any significant alcohol or caffeine intake. BMI was 25, TSH normal. Transthoracic echocardiogram, normal EF, normal LSIs. We discussed the absence of antiarrhythmic medications, AF ablations, refused antiarrhythmic medications, and wished to proceed with AF ablations. However, at this point, if anybody comes with the young age, we always discuss all the options. Okay. So the treatment, going for AF ablations currently, in our clinical practice, what we do, if patient is symptomatic, then definitely after beta blocker, the next step is antiarrhythmic drug medications. If the patient does not improve, doesn't maintain the sinus rhythm, we go for ablations. If the patient doesn't want to be on antiarrhythmic medications, go for ablations. Or if you give antiarrhythmic drugs and patient develops any side effects, that will be the indications of catheter ablation. This is how I practice. Okay, still. So we did the AF ablations, we did the cryo, EVI. Look at this, atrium was completely healthy and he had isolation of all the 4 pulmonary veins. I've been following this patient for the last 2 years, no episode of atrial fibrillations. Finally, antiarrhythmic medication after the 90-day period of, then we took it off, and I don't stop my Coumadin anticoagulation 6 months or 1 year, preferably 1 year, and finally he is off everything. He is continuing on beta blocker low dose and aspirin, which I believe has no role in case of atrial fibrillation nowadays. Let me go over the case 2, which I did recently. I'm here to follow him. 59-year-old Caucasian male with history of coronary artery disease with stents, presented with frequent palpitations with atrial fibrillation since February 2022. That was the first time atrial fibrillation was detected. So I would say it was atrial fibrillation of unknown duration that time. Symptoms continued despite transitions to sotalol. Paroxysmal atrial fibrillation finally got converted to persistent atrial fibrillations. He underwent electric cardioversion in May 2022, presented in October this year with progressive shortness of breath, back in persistent atrial fibrillation, repeat transthoracic echocardiogram, LVEF 55 to 60%. LSI was, this is wrong, it was 6.2 centimeter. Okay, TSH normal. I discussed and gave the possibility that persistent AFib with this kind of LSI is hard to maintain the sinus rhythm. So he needs to understand the reality of this complex procedure we are going to perform on him and what's the results of that. So, but he did not want anything else. He wanted to go for the ablations though. So I brought him in. Look at this. This is after I isolated all the veins, cardioverted. Still right and left carina were very active, and I decided to give the box lesion. Usually with cryo, when I added on RF ablations, give superior and inferior lines, that's enough. But he was not isolated yet, so I had to give the vertical lines, and finally he was completely isolated. He's yet to come for the follow-up, but I won't be surprised he's back in atrial fibrillations though. So that tells you about that. We'll go over those cases early. I don't want to spend too much time on East AFNet. I think Andrew did a great job. So the objective of this trial was the early treatment of atrial fibrillation for stroke prevention trial was designed to test whether a strategy of early rhythm control therapy that includes atrial fibrillation ablation also would be associated with better outcomes in patients with early fibrillation than contemporary evidence-based usual care. And this was the results which Andre showed very well. So in patients with recently diagnosed atrial fibrillation, an early rhythm control strategy was associated with reduced risk of cardiovascular mortality, stroke, heart failure hospitalizations, or acute coronary syndrome hospitalizations compared to the usual care. However, the two things which I don't have, two things were important. The adverse reactions, adverse reactions were higher in the early rhythm control group, it was 4.9%. Most likely, I would say probably use of antiarrhythmic medications. The nights the patient spent in the hospitalization did not differ, and LVEF did not change much. So this is the subset of East AFNet. Sub-analysis of the East AFNet trial demonstrated that early rhythm control therapy using antiarrhythmic drugs or AFib ablation is safe and reduces cardiovascular events in patients with heart failure. The clinical benefit of early rhythm control is not associated with greater improvement in LVEF compared to that observed in the usual care. Clinical benefit is observed across the spectrum of heart failure subtypes, suggesting that restoring and maintaining sinus rhythm via rhythm control therapy conveys the clinical benefit. A lot to go. So this was another subset for the AFNet trial. I'll quickly go over that. Patients with recently diagnosed atrial fibrillation and Chadwick score of more than 4 should be considered for early rhythm control to reduce cardiovascular outcomes, whereas those with fewer comorbidities may have less favorable outcomes with the early rhythm control. That means more the comorbidities, the better the results of early rhythm control. This was basically the meta-analysis of all these trials, and they also, summation of all of them, randomized trials and observational studies supported that early initiation of rhythm control treatment was associated with improved effectiveness outcomes in patients who had recently been diagnosed with AF. So the next one, I will take you to early AF trial. The early AF trial was presented in AHA 2020. Can I have 5 minutes? Okay. This was and then published in on January 28, 2021, back to back in the same issue. Early AF came and the stop AF trial came, which I am going to go over. Okay. So early AM trial, the background here I'll go quickly under the box. Antiarrhythmic drugs have limited benefit and potential toxicity. Ablation is more effective when performed early. Delayed ablation is associated with worse outcomes, including hospitalizations. And these are the objectives. Primary endpoint was time to first recurrence of any, which included both symptomatic and asymptomatic atrial tachyarrhythmia. And the secondary endpoints was first recurrence of symptomatic atrial tachyarrhythmia, total tachyarrhythmia burden, quality of life, emergency visit to hospitalizations, repeat ablation procedures, and serious side effects. So this is how they divided 303 patients, 154 randomized to first-line ablations, 149 randomized to first-line antiarrhythmic drugs, and within 24 hours, all of them were implanted with loop recorder. And daily care link transmission and the clinical encounter, 12 lead EKG at 1 week, 3 months, 6 months, and 12 months. And these are the criteria they followed for the quality of life assessments. And these are the patients included, patients never treated on atrial fibrillations, treated very low threshold atrial antiarrhythmic drugs. So we'll not go over that. These are the drugs they use. And this was the primary outcome: freedom from any atrial tachyarrhythmia on continuous cardiac monitoring, with absolute reduction in the ablation group of 24.9%. And secondary outcome, freedom from symptomatic arrhythmia, is still absolute reduction 15.2% with ablation group. And this was the secondary outcome, shows the burden, total burden of atrial fibrillation was greatly reduced in the ablation group as opposed to antiarrhythmic medications. So conclusions. The first-line ablation was associated with significant reduction in arrhythmia outcomes, time to first recurrence of any AF, atrial flutter or tachycardia, time to first recurrence of any AF, time to first recurrence of symptomatic and atrial tachyarrhythmia, and total burden of AF, days with AF. First-line ablation was associated with meaningful improvement in quality of life. Adverse events were similar between contemporary cryoablations and antiarrhythmic drug therapy. Almost there. So this trial came, this is a 3-year follow-up, which came basically of early AF. I'm going to quickly go over the conclusions of this. Came on just before I came here, November 7. Initial treatment with paroxysmal atrial fibrillation with catheter ablation was associated with lower incidence of persistent AFib or recurrent atrial tachyarrhythmia over 3 years of follow-up than initial use of antiarrhythmic drugs. So pretty good. So in the same issue of New England Journal of Medicine, a STOP AF trial came. So this is, I'm not going to go to the details of it, 18 to 80 years of age, enlarged left atrium more than 5 centimeters, excluded previous treatment with antiarrhythmic drugs, excluded previous LA ablations or previous surgical ablations, excluded. Okay, and the follow-up was non-invasive, not with the loop recorder, 12 lead cardiac event monitored. So, and that also showed the results where cryo balloon ablation as initial therapy was superior to drug therapy for prevention of atrial tachyarrhythmia recurrence in paroxysmal atrial fibrillation. Serious procedure-related adverse events were uncommon. That's what is STOP AF. I'm almost there. So this was another study, diagnosis to ablations, and that tells the shorter duration between the time of first AF diagnosis and AF ablation is associated with increased likelihood of ablation procedure success. Additional studies required to confirm these results and to explore the implementation of earlier catheter ablations and patient outcomes within current AF care pathway. So back to my case. This case I've been following for 2-3 years now. No recurrence of atrial fibrillation, no palpitations. This case, if he would have come earlier, agreed for AF, I believe, probably he would not lead to this size of left atrium, these changes in the left atrial posterior wall, and I'm still thinking that I hope I'll be very happy to see him in sinus rhythm, but I won't be surprised if he's back in atrial fibrillation. So with that, let me summarize. Patients with recently diagnosed atrial fibrillation with high burden of comorbidities should be considered for early rhythm control to reduce cardiovascular outcomes. First-line AF ablation is associated with significant reduction in arrhythmia outcomes, including time of first recurrence of any atrial tachyarrhythmia or time of first recurrence of symptomatic atrial tachyarrhythmia, total burden of AF, and days with atrial fibrillation. First-line AF ablation is associated with meaningful improvements in quality of life and symptoms, and cryoballoon ablation as initial therapy was superior to drug therapy for the prevention of atrial arrhythmia recurrence in patients with paroxysmal atrial fibrillations, longer duration between the first time between time of first AF diagnosis and AF ablation is associated with lower ablation procedure success and higher AF recurrence. Diagnosis to AF ablation time of 1 year or less is associated with 27% lower risk of atrial fibrillation post-ablation. And with that, I stop. Thank you for allowing me extra 5 minutes. Thank you.